Mr Weatherby.
Alistair Donaldson was a senior policy advisor at the British Council until he was posted to the DHSC Adult Social Care Policy Team, where he commenced work on the 30th of April 2020. He described complete chaos, his words, in the department on his arrival, with no one knowing who was doing what or where responsibilities lay. And even later he says that HR was unaware of how many people it was employing, even to the nearest 1,000. In his statement at paragraph 133, he says this: "My reluctant personal conclusion from what I directly witnessed is that the civil service I'm proud to be part of catastrophically let down the people it was supposed to serve. Whitehall and policymakers should not shy away from the fact that they presided over something that was more than a natural disaster, inevitably exacerbated in places by a few incompetent or reckless errors. Rather, the government public health response to COVID involved a series of catastrophic policy errors and an overall system performance that was, with notable exceptions, a profound failure, perhaps the greatest governmental policy failure of modern times." And then he continued with this: "This failure resulted in the unnecessary deaths of tens of thousands of British citizens, including a generational slaughter within care homes, many of those victims dying horrible deaths, often without the solace of their loved ones. Understanding the true causes of this failure is, I believe, owed to the victims, their families, to history and to the future." The importance of this is not only that he was a significant member of the DHSC ASC policy team, but he was responsible in large part for the Vivaldi study, which, as we've heard, was an important project set up in May 2020 to gather and analyse data from care homes in order to direct policy. Mr Donaldson rubbishes Matt Hancock's contention that the Vivaldi study supports the suggestion that discharge of thousands of untested patients to care homes in March 2020 did not contribute significantly to outbreaks or mortality rates. He describes such a position as, quote, untrue, and makes the stark point that because those discharged at the time were untested, the study could not have reached any such conclusion. Absence of evidence is plainly not evidence of absence. He comments that common sense and basic epidemiology would point in the opposite direction, that just at the time that hospital infections were rising exponentially, discharging untested patients would create a clear and obvious risk to care homes. The fact that there were other obvious risks did not diminish that. Mr Donaldson also takes on the work done by PHE to review the policy's impact, pointing out that those within PHE had skin in the game and that it was marking its own homework. Although Mr Hancock wants to rely on this PHE work, he's rather stuck by a WhatsApp exchange with his junior care minister, Helen Whately, dated the 13th of July 2020, in which he describes data relied upon by PHE from March as, quote, crap, and that government should have, quote, zero tolerance for it. No doubt you'll look closely at the March 2020 decision to discharge patients to care homes without testing, but currently you'll be doing so without hearing from Mr Donaldson or Lord Simon Stevens, head of NHS England at the time. We've asked you to review that decision and call them as witnesses with important evidence.
So just pausing there, Mr Weatherby, I haven't yet made up my mind about Mr Donaldson. I haven't made up my mind about Mr Donaldson.
I'm happily corrected. I was going to say we renew that request today, but no need. For countless families, the decision to discharge untested patients to care homes or to receive domiciliary care at that time was unfathomable. It's cold comfort to hear the unevidenced assertions of Mr Hancock or Professor Harries that it wasn't significant, or that discharges were not the dominant cause of infections in care homes. Every death was devastating. If there had been adequate testing capacity, would anyone have been discharged to a care home or to receive domiciliary care from workers who would then care for others without being tested? Of course not. Would care workers themselves have been tested earlier and more often? Of course. If there had been a properly functioning ASC sector, would there have been so many people requiring social care stuck in hospital at that time? Obviously not. If there had been proper pandemic planning and capacity, would care homes have had better isolation provision, better staffing levels and dedicated staffing provision, support for staff needing to isolate, proper and sufficient PPE, would the risks have been much reduced? Of course. Was sufficient done to free up provision in private healthcare settings? Was the right approach taken to limiting or stopping elective healthcare in the eye of the emergency? The reality is that with no preparedness and lost weeks from January to March, the government panicked. Under the dithering leadership of Mr Johnson and Mr Hancock, it was not only the failure to plan and prepare and resource before the pandemic, but the lost weeks from January to March, when performative government trumped candour. It was more important for them to pretend that we were okay than to act with speed and strength to catch up as far as we could. This is not mere rhetoric. From WhatsApps, we know that by early March, Mr Hancock and his junior minister, Helen Whately, only knew about 2 local authority pandemic plans for ASC. They'd taken no action on large-scale asymptomatic testing. There was an acute shortage of tests and PPE. I could add a lack of clear central guidance on IPC and a lack of support funding for homes and staff alike. Although the phrase generational slaughter within care homes may sound hyperbolic or rather colourful language, it chimes with the experience of thousands of our families. In an early module, we heard that former Prime Minister Johnson told senior advisers that COVID was just nature's way of dealing with older people. And Patrick Vallance recorded in his diaries that Mr Johnson appeared obsessed with older people accepting their fate. Meanwhile, Mr Hancock was asserting that a protective ring had been placed around care homes, an assertion he now tries to spin out of by suggesting that it was, quote, clearly a piece of rhetoric. By definition, people drawing on care and support were more likely to be vulnerable to COVID because of age, comorbidities and disability. They were not just casualties of some natural selection process. As we'll see from the evidence in Module 6, they were not protected by some ring of steel, real or imagined or rhetorical. In some settings, those receiving social care fared well. In others, catastrophic outbreaks led to multiple deaths. This was not mere chance, but largely down to themes which are now familiar to the inquiry: lack of planning, lack of resourcing generally, the slow injection of emergency pandemic funding, lack of testing and PPE capacity. It's not for this inquiry to investigate whether, of itself, the fragmentation of the ASC sector and the lack of strategic overview or policy or resourcing during normal times was or is sensible. But it is for this inquiry to look at whether this provides a viable framework through which emergency planning and operations can work. In England alone, ASC services are the responsibility of local authorities, outsourcing to more than 18,000 providers, with the centre, the DHSC, responsible only for the legal framework and policy by which local authorities are to discharge their duties. We know, for example, that this framework resulted in a position where ministers did not know even how many care homes there were by March 2020. I think it's fair to say that they knew how many hospitals they were. So why the lack of such basic knowledge in social care? Chris Llewellyn of the Welsh LGA provides an answer. He says, social care is viewed as a secondary service or add-on, not the critical frontline service that it really is. A system which relied upon staff caring for a number of residents could not overnight pivot to one where dedicated staff could look after individual residents. In many settings, staffing levels meant that there was considerable reliance on agency workers who moved between homes, and with domiciliary settings, that would be the norm. Although some care homes no doubt managed to create isolation areas, these were people's homes, not designed for siloed living. And for many, this was impossible because of the physical accommodation, staffing and resources. We'll hear a more nuanced view from Sajid Javid, who will assert that ASC requires a joined-up approach between care providers, local authorities, the NHS, UKHSA, MHCLG and the DHSC. No doubt there's truth in that, but if so, where's the evidence of any functioning pandemic collaboration between all those agencies or multi-agency interoperability plans? If the UK and its constituent parts failed to prevent infection across many settings, failed to have proper staffing provision, failed to have sufficient testing and PPE, it's perhaps no surprise that it failed on visitation too. Many others will speak to this issue, but it's of huge importance to the families, many of whom lost loved ones whom they were prevented from seeing for weeks and months prior to their deaths, many living with dementia and other conditions or comorbidities which made isolation from loved ones so much more unbearable. As in all other modules, we urge the inquiry to focus on how the response to the pandemic in the ASC sector tackled or even acknowledged existing discrimination and inequalities. We cited some of the available and shocking data in our written submissions, but mortality rates for ethnic minority staff were massively disproportionate to their white colleagues. Care workers were overwhelmingly women and with lower than average socioeconomic status, including many in precarious positions. What was done? What was planned? What policies were brought in to address these disparities? It's well established that those with learning disabilities, autism, dementia, as well as those with physical disabilities, fared particularly poorly during the pandemic. What exactly was done to address these obvious issues in planning or the early stages of the emergency response or thereafter? It appears very little. As with all these questions, what's the position now in 2025? Have lessons been learned? And if so, do they inform what went wrong in 2020? If lessons have not been learned, are we really destined to fare just as badly and disproportionately with respect to racialised minorities and disabled people as before? Finally, I turn to the lived experience evidence from the bereaved families. You're to hear from two of our family members, Jane Weir-Verjboschke and Linda Ann Dinsdale, and a number of others from the other bereaved groups. You've determined that the inquiry will not hear from the CBFFJ UK organisational witness, Jean Adamson, but take account of her detailed witness statement, which in turn not only details her own experience, but sets out the experiences of a number of others. As you'll have seen, the statement draws attention to the consequences of having a fragmented system and calls for unified national care systems within each of the 4 UK jurisdictions to enable proper emergency planning and response. We urge you to make that a key recommendation for Module 6, but we add to that a rebalancing of the health and care sectors so the latter is no longer a poor relation. Better data, better regulation, proper emergency and pandemic planning, which includes resourcing, support for staff, adequate IPC, testing and PPE. We urge you to recommend that tackling racial and disability discrimination in the sector not only needs to be a higher priority in normal times, but an integral part of emergency planning. It was plainly neither when the pandemic struck. Jean's statement on behalf of CBFFJ UK draws attention to the consequences of fragmentation, lack of strategic oversight, planning and proper resourcing. For CBFFJ, moving forward, the key issue is that without national care systems, there will be absolutely no basis through which any other recommendations you make will work. CBFFJ calls out the callous way that family members were treated by politicians and policy makers, referring to them as bed blockers and people nearing the end regardless of the virus. This theme was exacerbated by the experience of many family members regarding inappropriate DNA CPRs and blanket visitation policies. The statement reflects that those in charge of policy lost their moral compass in dealing with those receiving care. Jean's dad was a Windrush pioneer who came to this country in 1956 to rebuild post-war Britain and worked on London Underground. Aged 98 and in a care home, he was not a statistic or a number. Aldred Clearfirst Adamson was a dignified senior citizen who should not have been a lesser priority because of some actuarial calculation. In his case, untested patients had been discharged into his home less than a month before he died without precautions being taken, a matter expressly raised by his family at the time. Arthur Argyll died in May 2020. His daughter Sarah had to fill gaps in his care resulting from chronic low staffing ratios, which impacted on him being shielded from infection. On the 26th of May 2020, Kath Sexton was the last of 24 people in her care home to die from COVID in a 3-week period. Her daughter considers it probable that this was linked to the policy to discharge untested patients from hospital in March. Marie Irwood removed her mother Margaret Jean Smith from a nursing home, having been told by the manager that they'd been required to take untested patients from the local hospital, and having raised concerns about an apparently symptomatic care assistant who'd returned from Italy caring for her mother without PPE. Unfortunately, Margaret had already contracted COVID and died 2 days after returning home. By contrast, there's evidence of care facilities which managed to provide care safely. Amos Waldman's grandma, Sheila Lamb, sadly died in a care home in early April 2020. At the time, Mr. Waldman was himself becoming a trustee of another care home, which cared for adults with both learning and physical disabilities. In Jean's statement, she sets out Mr. Waldman's detailed explanation of the measures taken by that care home, which managed to remain COVID-free until November 2020. It includes an earlier lockdown than the 23rd of March national one, proper PPE provision, dedicated staffing provision, full testing and support for staff who were self-isolating. Mr. Waldman's account is one of many which show that care home devastation was far from inevitable. It was avoidable with planning and early proactive management. His account also highlights that many of the families we represent are not only bereaved, but health or social care or domiciliary carers themselves. The catastrophe in the care sector was not of their making, and it did not need to be. The bereaved, their loved ones, and carers deserved better. Thank you, my lady.
Thank you very much, Mr. Weatherby.